100 years ago, in 1921, the New York City Health Department opened its first district health center in East Harlem. This pilot project co-located health programs, government programs, and community-based organizations under one roof to meet the health needs and improve the health of the community.
It was a time when the communities in East Harlem in particular were really piecing themselves back together in some ways.
Community-based organizations, social service agencies, the New York City Health Department, and the Red Cross worked very closely together and were able to get a lot of work done, as is often the case in emergencies, catastrophic situations, war zones, wartime.
And then when those times are over, those times of crisis, we tend to go back into our silos of operation and don't keep up that kind of momentum and efficiency, really. Part initiated by the Red Cross at that time. They brought together neighborhood residents, clearly, who are in the spaces, but really having a place-based approach.
It was around collaboration to bring together health and social services in one location, in one building, so that members of that community had really, an easy way to make sure that their needs were being met.
They were able to collectively agree upon infant mortality was a focus area.
They were also looking at things like cancer and tuberculosis. And they were also looking at how to get health messages out to the community in a way that's effective.
It set us up for a way that we can not only deliver services, but also show how collaboration can really work in this city.
Through the 1940s, the district health centers provided child health services, dentistry, nutrition education, and more. After the success of East Harlem, the department opened district health centers across the 5 boroughs. These health districts would lead to a neighborhood-focused understanding of health in New York City and to health interventions tailored to different communities.
And it wasn't because of lack of access to care, but also sanitary issues, housing conditions, yellow fever, cholera, smallpox. And so we knew that we needed these very local, focused, driven strategies.
World War II and other events led to the defunding of the district health centers as resources went elsewhere. That is, until 2003, when the health department renewed its neighborhood focus and established district public health offices. These offices promoted health equity through resources, programming, and partnerships in New York City neighborhoods with the highest rates of illness and premature death: the South Bronx, East and Central Harlem, and North and Central Brooklyn.
It provided us that grounding, that stability, that nurturing environment that we needed.
Communities need a presence of public health in their neighborhoods. That's always there, not one that comes and goes.
It helped us make our dreams into a reality because it just provided that safe space, that nurturing environment.
Today, the department's neighborhood health action centers continue this legacy in the Bronx and Brooklyn, in addition to East Harlem. The action centers bring together healthcare providers, city agencies, and community-based organizations to create a one-stop shop for community members, providing familiar services as in the 1920s. The programming includes childbirth education and family wellness suites for parenting classes, teen sexual health, support for children with asthma, nutrition education, overdose prevention training, and much more.
This is an opportunity to have some local presence and some physical presence and understanding of what is actually happening in the neighborhood and being able to be responsive to that in real time, but not only response, being able to set up systems and structures that act in a more kind of preventive way.
You can come in there and meet community health workers. You can come in there and get support around getting a city ID that gives you access to different places. That for people, for example, who are immigrants who may be undocumented, with that creates a lot of barriers in that community. But this breaks those barriers.
Even in one of our action centers in Brownsville, there is a dental suite.
We also had services there around HIV. We had services around maternal child health. We had services for people who are seeking literacy training and education.
Using these spaces and renewing them by investing in them and remodeling them and kind of making them spaces that feel welcoming, warm, and safe and clean. That experience of being in a safe space is healing, actually.
They could expect first a warm smile, a greeting, because what we wanted to make sure was that it didn't really just represent sort of a hospital per se. We wanted to make sure that it represented the community from the moment that you walk in. We have a calling to not only improving health, but also making sure that we are implementing a racial and social justice lens. That's how public health started.
And so this renewed focus really started to elevate this context of a place-based approach, but also a race consciousness around the root causes of why these inequities existed.
And we could see in these neighborhoods that a lot of the inequities really exist here. So when you look at diabetes or heart disease, or you're talking about opioid overdose deaths, they're very much in the neighborhoods and have been in these neighborhoods since the start of the district public health offices. An equity approach, the benefit is for everyone, because as we're able to address these inequities and really ensure that every single person in this city has the most optimal chance to get better health, it's going to improve our overall healthcare delivery system, taking off the burden of our emergency departments, taking off the burden of how we use our healthcare dollars, so that we can really focus on prevention.
And so to be able to think forward 100 years, to me, it really looks like continuing to double down and recommit to place-based investments in the communities that need to be our priority. That is an action, a model, a strategy that I suspect will be used for the next 100 years and likely, if we're lucky, used even more effectively going forward, because it does need to be expanded.
They knew then, when they got started with this idea, right after a really brutal war, World War I, that we not only need more money to be invested in communities than an immigrant community as it is today, East Harlem was, but we also need better alignment, better coordination, and who better than the health department to coordinate the many inputs that people need: housing, nutritious food, not only health services to be healthy. I hope that all sounds familiar because it continues to guide the idea of neighborhood health today.